All right. Hello. Today we're going to be talking about adductors and abductors of the hip joint. So when you're talking about the hip joint, it's one of the most flexible joints in the entire human body. The many muscles of the hip provide movement, strength, and stability to the hip joint and the bones of the hip and thigh. There are four main muscle groups in the hip joint. You have the anterior group, the posterior group, the adductor group, and the abductor group. Of course, today we're only focused on two groups. That would be the adductor group and the abductor group. All right, so let's talk about hip adductors. The best way to remember your hip abductor muscle group is by the acronym peanut butter leaves me greasy, right? As you can see, his sister is teaching him his hip adductor muscle groups, right? Peanut butter leaves me greasy. And he's having a field day. All right, so the hip adductors are a group of five muscles that consist of the pectineus muscle, the adductor brevis muscle, adductor longus muscle, adductor magnus muscle, and the gracilis muscle. Peanut butter leaves me greasy. All right, so let's talk about the pectineus muscle. And you got to excuse me. It's probably going to sound like I'm speaking or learning a new language. Some of these words are tongue twisters, but just work with me. Work with me. Okay, so the pectineus muscle. Origin is space 1 inch wide on the front of the pubis, just above the crest. Insertion is a rough line leading from the lesser trochanter down to the linea aspera. Action is flexion of the hip, adduction of the hip, external rotation of the hip, and anterior pelvic rotation. Palpation is just lateral and slightly proximal to the adductor longus and medial to the iliopsoas during flexion and abduction. Innervation is the femoral nerve, L2 and L4. Exercises that strengthen this muscle are the side leg raises, the wide leg squats, standing lateral leg raises. If you want to stretch this muscle, the best muscles are the kneeling lunge and the overhead stretch. So let's get into the adductor brevis, the butter part of the acronym. The origin is the front of the inferior pubic ramus, just below the origin of the adductor longus. Excuse me. Insertion is the lower 2/3 of the pectineal line of the femur and upper half of the medial. Actions: adduction of the hip, external rotation as it adducts the hip, assist in flexion of the hip, and assist in anterior pelvic rotation. All right, palpation. Deep to the adductor longus and superficial to the adductor magnus. Innervation is the obturator nerve, L3 and L4. Application, the adductor brevis provides powerful movement to the thighs when you're moving them towards each other. The best exercise, I would say, would be like a thigh. I think it's a thigh toner. That's what you call them. You put it in between the thighs and the woman will move her thighs toward each other with resistance. A thigh toner is the best exercise when you're trying to strengthen your adductus brevis. All right, so let's get to the adductor longus. Origin is interior pubis, just below the crest. Insertion is the middle third of the linea aspera. I told you I'm working on it. Action is adduction of the hip, external rotation as it adducts the hip, is an assist in flexion of the hip, and an assist in anterior pelvic rotation. All right, so the most prominent muscle proximally to the anterior medial thigh, just inferior to the pubic bone with resisted adduction. In inversion is the obturator nerve, L3 and L4. This muscle may be strengthened by using the scissors exercise. It can be stretched in the same manner as the adductor brevis. Pretty much all of the hip adductors can be strengthened and stretched using the same stretches and exercises. But some, like I just explained to you with the thigh toner, are specifically for that particular muscle. Adductor magnus. Origin is the edge of the entire ramus of the pubis and the ischium of the ischial tuberosity. Insertion. The whole length of the lineo aspera medial condyloid ridge and the adductor tuberal. Action. Adduction of the hip, external rotation as the hip adducts, and extension of the hip. Palpation. Medial aspect of the thigh between gracilis and medial hamstrings from ischial tuberosity to adductor tuberal with resisted adduction from the adducted position. Innervation. Okay, it's interior and posterior. Interior would be the obturator nerve, L2 through L4, and posterior is the sciatic nerve, L4, L5, S1 through S3. This muscle is used in the breaststroke, kick and swimming, and horseback riding. Stretching and strengthening this muscle is the same as the adductor brevis and longus. I just explained to you that pretty much when you're stretching your hip adductors, when you stretch them, you're stretching pretty much all 5 of them because they're all can be stretched and strengthened doing the same ones. So the gracilis muscle, all right, anteromedial edge of the descending ramus of the pubis. The insertion would be anterior medial surface of the tibia, just below the condyle. Action. Adduction of the hip, weak flexion of the knee, internal rotation of the hip. It also assists with flexion of the hip and weak internal rotation of the knee. Palpation. A thin tendon on the anteromedial thigh with knee flexion and resisted adduction just posterior to the adducted longus and medial to the semitendinosus. Yeah, semitendinosus. Semitendinosus, sorry. Innervation is the obturator nerve, L2 through L4. Application, this muscle performs the same function as the other adductors, but adds some weak assistance to knee flexion. Again, it's strengthened and stretched with the same exercises as the other adductor muscles. Let's talk about hip abductors. All right, so hip abductors are the gluteus medius, the tensor fasciae latae, and the gluteus minimus. These are basically the 3 primary muscles in the hip abductors. All right, so the gluteus medius origin is lateral surface of the ilium just below the crest. Insertion is the posterior and middle surfaces of the greater trochanter of the femur. Action is abduction of the hip, lateral pelvic rotation to the ipsiolateral side. Gluteus medius, continued. Palpation is slightly in front and a few inches above the greater trochanter with active elevation of the opposite pelvis from a standing position. Innervation, superior gluteal nerve, L4, L5, and S1. Application. Typical action of the gluteus medius is seen in walking. As the weight of the body is suspended on one leg, this helps the muscle to prevent the opposite pelvis from sagging. So, when you take that step, it supports it. But if this was out of commission, it would just basically, sag. Exercises that strengthen this muscle are the weighted deadlift, the lunge, and weighted squats. Excuse me. Exercises that stretch this muscle would be the pigeon pose, the figure 4 stretch, and leg crossovers. The tensor fasciae latae. Tensor fasciae latae. Tensor fasciae latae. I'm working on it. Origin is the anterior iliac crest and surface of the ilium just below the crest. Insertion is 1/4 of the way down the thigh onto the iliotuberal tract. Action is abduction of the hip, flexion of the hip, lateral pelvic rotation to the ipsiolateral side, tendency to rotate the hip internally as it flexes, external rotation of the knee, anterior pelvic rotation. All right, so palpation is the anterolaterally between anterior iliac crest and greater trochanter during internal rotation, flexion, and abduction. Yeah. Superior gluteal nerve, L4, L5, and S1 is innervation. It's important in helping direct the leg forward so that the foot is placed straight forward in walking or running. So this nerve or this muscle works to keep your foot perfectly straight forward. You strengthen with the hip extension of a bent and straight knee and a single leg bridge. Most effective stretch for the TFL, that is way better. The TFL, instead of pronouncing all that, Jesus, is the knee down hip flexor. All right. Gluteus minimus. Origin is the lateral surface of the ilium just below the origin of the gluteus medius. Insertion. Anterior surface of the greater trochanter of the femur. Action is abduction of the hip, lateral pelvic rotation to the ipsiolateral side, internal rotation of the femur abducts, flexion of the hip, and anterior pelvic rotation. Palpation. Deep in the gluteus medius, covered by the TFL, between the anterior iliac crest and greater trochanter, doing internal rotation and abduction. Innervation. Superior gluteal nerve, L4, L5, and S1. It's used in powerfully maintaining proper hip abduction while running. So again, these nerves or these muscles is what gets you running strong and walking good as well. So if you have any problem, pretty much as your hip goes, you go. So So you want to take care of that hip and keep that hip nice and strong. Exercises, like I said, it's effective in running, hopping, and skipping. So you want to strengthen it. Just do those 3 things right there and you can strengthen it. Stretches are the same as the gluteus medius. All right, so each year, 120,000 Americans have hip replacement surgery. Each year, right? The hip musculature must be strong and flexible to resist forces encountered during activities such as walking and stair climbing to minimize stress on the hip joint, right? Like I said, as your hip goes, you go. You do a lot of walking, you do a lot of climbing, you do a lot of running if you want to be active. You cannot be active if you have a weak hip. So you must do hip exercises. You must do hip exercises. Like I said, 120,000 people or Americans each year have hip replacement. And eventually, as the age of an individual increases, the stability of the hip joint decreases. So the older you get, the more you should continue to work on your hip joints, your hip abductors, your hip adductors, to keep you from having to have this surgery. Because doctors only recommend having this done once. So after that, that's pretty much it. That's why I said, as your hip goes, so goes you, and so goes everything that you're trying to do. You want to be mobile, you got to keep that hip strong. But yeah, strengthening the adductors and abductors helps to stabilize and even delay replacement. So odds are, like I said, if you keep them strong, you won't have to worry about surgery or getting them replaced, walking problems, running problems, anything of that nature. You'll be good to go. That's my presentation. Works cited page. That's it.